أي نعم.
نبدي إن شاء الله. بسم الله الرحمن الرحيم. Our lecture today is myelopathy. Myelopathy as a term is any disease of the spinal cord. At the beginning, the spinal cord anatomy included the definition of the spinal cord. Spinal cord is an extension, is a tubular extension of the central nervous system. As you show in this diagram, it is contained within a bony spinal canal, the vertebral canal. It originates from the medulla oblongata, the caudal part of the brainstem, and continue caudally to the filum terminal. Filum terminal is a fibrous extension of the conus medullaris. Conus medullaris is the caudal part of the spinal cord. Filum terminates attached to the coax. As you show in this diagram, spinal cord enlarged in cervical area and in the lumbar area, because this area of the spinal cord supplied the upper limb and the lower limb. Spinal cord containing ascending and descending tracts. The ascending tract is the sensory, as you know, the sensory ascend to the thalamus. The descending tract, the motor, specifically, the descending from the motor cortex, reaching the spinal cord. The neurons is in the middle. As you show in this diagram, the neurons oppositely to the brain is clustered in the central area of the spinal cord in four-leaf clover shape, just like that in Canadian flag. Spinal cord contain 31 segments. The largest part of the spinal cord, the lumbar area, is not in position with the corresponding vertebrae. So there is extension of the axons to reach the corresponding vertebrae, to reach the intervertebral foramina and the outlet of the axons. So this part called clusters of axons of the neurons, the roots called coda equina. When we mentioned spinal cord, we should mention coda equina, because a coincidental finding of coda equina lesion with the conus medullaris, the caudal part of the spinal cord, and should be differentiated. Although coda equina is lower motor neuron, but we should differentiate it from the lesion in the caudal part of the spinal cord. Okay. Spinal cord during embryological development growth, it will lag behind the vertebral column. It's not the same length. This lag causes that the difference between the segment and the corresponding vertebra, as you show in this diagram, maybe in the cervical area is corresponding to the same upper cervical, but as I mentioned, the caudal part, which is conus medullaris, is lagged. It ended in lumbar vertebrae 1. So sacral and coccygeal, we have only one coccygeal, is have a long axons, not like that of upper cervical. In this table, I will put, I will put it in simple way. It is not simple as this, as that mentioned in this table, but I will put it in this simple way just to be memorized. The spinal cord level with corresponding vertebral body in upper cervical is the same. Cervical 2 corresponding to vertebral column 2. In lower cervical, it will be one level higher. In upper thoracic, it will be 2 level higher. In lower thoracic, it will be 3 level higher. In lumbar, all the lumbar, which is 5, the corresponding vertebral body is from T10, T11, and T12. Sacral and coccygeal, it will correspond, the corresponding vertebral body is T12, L1, only 2 vertebrae. And all the sacral and coccygeal, the 6 segment, corresponding to the 2 vertebrae, which is thoracic 12 and lumbar 1. After this simple introduction as a prelude for what we have a concern, the clinical approach to a patient with spinal cord lesion with myelopathy. The following question should be answered in any patient with a spinal cord lesion. Is what are dealing with is a spinal cord insult? This question answered in 2 ways. First, what is the hallmark for the spinal cord lesion? In other way, when do we suspect myelopathy? The second point is differentiated from its differential diagnosis. The second, what is the temporal profile of the spinal cord? If we consider this lesion as a spinal cord and consider this clinical manifestation is consistent with the spinal cord lesion, we should answer this question, what is the temporal profile? Then, what is the specific level of the lesion? Thoracic? Is it lumbar? Is it sacral? Even in cervical, we should differentiate. It's upper cervical or lower cervical, or we should mention specifically, is it C5, C6, C7, C8, and extra. Then, with the specific level, we should mention what is the pattern of a spinal cord lesion, and all the diseases affected the spinal cord classified or have unique, or sorry, not unique, it's categorized in specific pattern. Categorized with a specific pattern, and we'll take in detail what is the level and what is the pattern. The last question should be answered: is there is a concomitant affection of other part, cranial neuropathy, optic neuropathy, cerebellar ataxia, meningitis, brainstem lesion, with any concomitant affection of any part can raise the concern of a specific diseases. For answering the first question, is what are dealing with in the spinal cord insult, the presence of below which sensory, motor, autonomic function is disturbed, and above it everything is normal. This level is the hallmark of a spinal cord disease. So the level is the address for spinal cord lesion. Maybe you know very well most of you didn't even level or autonomic level. The level is not only restricted to the sensory level. It is sensory level, motor level, and autonomic level. But the sensory is highly sensitive. So sensory level and sensory level. Or diminished of sensation below the specific precise level. When we said the level, the sensory level below D10, say D10, the level of umbilicus, it was clear that denote the lesion is at D12, D10. If it's bilateral, in unilateral there is something a little bit different. But in bilateral, it means the lesion below D10. I said sensory level is more specific. It is sensitive, but it's. I will add something. It is sensitive and specific, and difficult, very difficult to have something different in any lesion other than spinal cord. Maybe the radiculopathy lesion in the roots may mimic that, but with digging in the examination is clearly we can differentiate from root lesion. If the lesion have hemi, not bilateral, only one side, the sensory level will be 2 levels below the lesion. Why? Because you can please look to this diagram. The posterior horn will be sensory and crossed to the contralateral spinal thalamic tract for pain and temperature and ascend to the thalamus. This diagram is 2-dimensional. It is not exactly as shown in this diagram. Usually, the posterior root enter the posterior horn, but not across the midline. It will ascend in the ipsilateral side in the posterior horn for about 2 segments, then across the midline to the spinothalamic tract. But if the lesion is bilateral, it will make no difference. But in unilateral, it will appear. If the lesion is D10, it means if the sensory level, at D10, it means the lesion 2 segment below, 2 to 3, or you can say 2. Motor level, loss of power below. It is not specific and definitely not sensitive, especially in both lower limb. If the patient have paraplegia, it means the lesion below D1, T1. Why? Because T1, if the lesion in T1 and above, the upper limb is involved. So it is not specific, because below D, it can be above L1, below D, no more than that for the motor level. If the lesion above C5, it will be tetraplegia. And tetraplegia, without involvement in the upper and lower limb, it means the lesion above C5 in upper cervical and below the brainstem. Autonomic level is a little bit difficult to elicit, but we can do it with a tuning fork or even a spoon. And when you move the spoon rostrally from the lower limb, if there is autonomic dysfunction, there will be no sweating. So the tuning fork or the spoon goes in the dry skin very easy. When you reach the area of normal sweating, will be resistant to movement, and at this point you reach the autonomic level. It is a little bit difficult to elicit, not like that of sensory level. Segmental sign. What do you mean by segmental sign? If the lesion at any level, take it as C5, which is commonly involved. Segmental level, it means everything below C5 is clear. In sensation, there is loss of sensation. In motor, there is sign of upper motor neuron lesion. But what about C5 itself. What will give? It will give something different. For sensation, it will give hyperpathia. If you remember what is hyperpathia from the lecture of sensory system. In other words, there will be, due to hyperpathia, a tenderness. So there is a band of tenderness. This is the segmental sign. If the lesion at the segment of C5 level in the spinal cord, there will be band of hyperpathia, tenderness, normal, harmless stimuli can produce severe pain. This is hyperpathia, is a sensory segmental sign at the level of the lesion. This is appeared only at the level of C5, for example. For the motor, below the lesion, definitely there is upper motor neuron lesion. But what about the segment itself? The segment itself, due to involvement of the anterior horn, there will be lower motor neuron lesion instead of upper motor neuron lesion, because the involvement of the anterior horn cell. And as you know, there is a dominancy in neurology. If there is in the concomitant upper and lower motor neuron lesion, the lower motor neuron lesion will be appear. So at the segmental sign, there is lower motor neuron lesion. For example, if the lesion at the level of C5, there will be absent of biceps reflex and hyperreflexia in the supinator and triceps. Spinal shock. What do we mean by spinal shock? An acute spinal cord lesion up to 2 weeks, there is sign of lower motor neuron lesion rather than upper motor neuron lesion. This is due to shock state of the neuron. But with time, step-by-step fashion, there are signs of upper motor neuron lesion will appear. So at the first 2 weeks, up to 2 weeks, there will be flaccid paralysis, hypotonia, hyporeflexia, but with time, the signs of upper motor neuron lesion will appear. This is called spinal shock. But if this patient has persist lower motor neuron signs and not change to upper motor neuron signs, in this situation, it means there is a necrotizing spinal cord lesion, which cause lower motor neuron lesion rather than upper motor neuron lesion. The explanation that due to involvement of anterior horn cell, because the necrotizing type of the spinal cord, it will be dead tissue. And the dead tissue, the neurons in the anterior horn, and the signs of lower motor neuron lesion persist. Although this is uncommon, but we can face it. What about the clinical presentation of spinal cord lesion? We know this approach, what is the pathophysiology of the manifestation, but what is the clinical presentation? The first step in constructing a differential diagnosis in myelopathy is determine the location as any part of a nervous system, but beside the localization to the spinal cord, you should have localization to the level of the segment that involved in the disease. The most common symptoms are difficulty in walking, stiffness or weakness in the arms and leg, episodic muscle spasm, cramping, bowel incontinence, urinary urgency or hesitancy. So, the presentation either motor, most probably, and it could be sphincter disturbance. Pain. The most common complaint in general medicine is pain. But what types of pain we can link it to the spinal cord? There is 3 types of pain. Local, which is usually not the spinal cord, but the vertebral column, which can give local pain. The second type of pain is radicular pain. Radicular pain, it means root pain. Root pain usually felt at more distant site. Yeah, if the lesion, for example, any irritating lesion to the root in C5, for example, it will not be at the area of C5. If we feel pain at C5, at the local, it will be bony pain to the cause of root irritating. But the root itself, if a pain, we will feel it in the shoulder. So neck pain is not a usual manifestation in neurological disease, but shoulder pain is very common. The third type of pain is pain due to spinothalamic lesion, the spinal cord itself. This type of pain usually L-localized. Okay? Organizing L-localized. Usually diffused with cold unpleasant in the extremity. Then, after pain, what is the level of the lesion? There is a constellation of manifestation which give specific levels localizing sign. First, the cervico-medullary junction. The cervico-medullary junction give a special type of presentation because what happened in the anatomy imply the etiology. The cervico-medullary junction is the area of decussation of the corticospinal tract. If the lesion at this area it will give a crural paralysis. Hiraj. For example, right upper limb, left lower limb. This is due to the area of decussation, clockwise and anti-clockwise. What do you mean by clockwise and anti-clockwise? If there is compression and slowly progressive compression to the area of decussation, it will be clockwise or anti-clockwise according to the direction of the compression. Start, for example, in the upper right, upper limb, then right lower limb, then left lower limb, then left upper limb, clockwise or anti-clockwise, in the opposite. If the adjacent medullary centers, which is resultant in vasomotor and respiratory collapse, appeared, also denote that cervical medullary junction is insulted. Cervical cord, higher cervical cord lesions are frequently life-threatening. Why? Because due to involvement of phrenic nerve, which can give respiratory embarrassment. Also, in upper cervical area, we can find Horner syndrome. Thoracic level, maybe not like that of upper cervical, but sensory level is the best way for localization. Usually, as a motor level, we have paraplegia, involvement of both lower limb with the sparing of the upper limb, except for T1. But below T1, other thoracic, which is a 12 segment from T2 to T12, usually the patient have paraplegia, paraplegia defined as involvement or insulted of both lower limb with normal or sparing upper limb. Midline back pain, local pain at the corresponding vertebrae is one of the clinical manifestations of thoracic cord lesion. In lumbar area, except for L3, which can give lower motor neuron lesion in L3, segmental sign in L3, so there is knee reflex absent with exaggerated of ankle reflex and Babinski sign. But in other lumbar area, it is less easily localized. What about sacral conus medullaris syndrome and coda equina? Sacral cord, conus medullaris, the caudal part of the spinal cord, should be differentiated from coda equina. As I mentioned, for two reasons. First, because sometimes both of them appeared together, and sometimes because it's nearby, should be differentiated if it presents by itself. The conus syndrome, there will be absent ankle reflex and extensor plantar response. This is characteristically to the conus syndrome. Yes, there is other causes for this combination, but conus, it's characteristic for conus syndrome in spinal cord lesion. Bilateral saddle anesthesia, اللي هي من C3 ل C5, saddle anesthesia يعني منطقة السرج. early sphincter syndrome. Coda equina, which is radiculopathy rather than spinal cord, have something different. The address to the radiculopathy is pain, and radicular pain is severe. So it's definitely differentiated from spinal cord lesion by pain, by radicular pain, which is agonizing pain. In coda equina, which is root lesion, asymmetrical leg weakness or sensory loss. And due to motor involvement, it will be also asymmetrical in involvement of this area. Okay, what is the pattern? We mentioned the level. Is it cervical medullary? Is it upper cervical? Is it thoracic? Is it sacral? Is it lumbar? What is the pattern? Patterns of spinal cord lesion. First of all, we should differentiate: is the lesion is extramedullary or intramedullary? Extramedullary, most of the I think you take it in the neurosurgical lectures as a spinal cord compression. Extramedullary, the lesion from the outside of the spinal cord compressed the spinal cord. Intramedullary, the lesion, intramedullary cord lesion, the lesion from within, from inside the spinal cord. So, at first, you should differentiate spinal cord lesion. Is it extramedullary or intramedullary? In extramedullary, the lesion from outside, so it will facing the root. So there is radicular pain, and radicular pain is often prominent. In intramedullary, there is funicular tract pain, because the lesion will be, if there is pain, due to the lesion of spinothalamic tract. If look to this diagram, if the lesion from outside, so the compression will be to the not this diagram. خلينا نرجع لا بعيد صار. تذكرون ال crossing from one side to other side. من posterior column, posterior root to the posterior horn cell, across the midline to the spinothalamic tract. So, in the sacral area, it will be here. It will be here, sorry, outside. اللي يجي بعدها lumbar, it will be more inner. اللي يجي بعدها thoracic, it will be more inner. Cervical. So any lesion from outside, it will be compressed the sacral area. So there is early sacral sensory loss. The opposite, if the lesion from within, intramedullary, the sacral area is the last part to be affected. If the lesion from extramedullary, it will be compressed the corticospinal tract before compressing the anterior horn, because anterior horn is more inner, more central part. So, upper motor neuron appear before the lower motor neuron. the sphincter usually in the what we call the intermediate horn. If the lesion from within intramedullary, the sphincter is early abnormality. But if it's extramedullary من برا جاي, لا, it will be late sphincter abnormality. So this is what we differentiate between extramedullary and intramedullary cord syndrome. There is a syndrome called Brown-Séquard hemicord syndrome. Although it's uncommon, but it's very important to be mentioned. Maybe extramedullary or intramedullary, but the most common cause of Brown-Séquard is surgical causes, trauma or spinal cord compression. There is hemi. So if there is hemi, the lesion in the dorsal column, اللي هي vibration and position sense and light touch, will be affected ipsilateral, because the decussation of posterior column will be in the brainstem, but corticospinal tract is decussate and reach the spinal cord in the contralateral part, and the spinal thalamic is decussate in the spinal cord. So any lesion in the hemicord, it will be ipsilateral, position sense, vibration, light touch, and contralateral motor and pain and temperature. There is different intramedullary pattern implied specific pathology, and we will mention, when we mentioned the diseases, it will only, I will say, this is cord transection, this is selective tract involvement, this is central cord lesion, this is anterior two-thirds. This is syndromes, and for each syndromes there is a causes. Cord transection, it means bilateral involvement, and I think all the groups that take the program of clinical neurology يعني سمعوها من عندي. Bilateral, it doesn't mean symmetrical. So cord transection, it means bilateral involvement. It doesn't mean symmetrical, and it doesn't mean all parts of the spinal cord involved, but it means there is involvement of bilateral. Usually cord transection, the causes of cord transection is inflammatory, infective and non-infective. Selective tract involvement, the only tract or tracts. For example, the posterior lateral column, which is found in sub-acute combined degeneration of the spinal cord, and in folic acid deficiency and copper deficiency. Posterior column, specifically characteristically involved in tabes dorsalis, in tertiary syphilis. Central cord syndrome, the central canal of the spinal cord is extended. So the lesion in the central part of the cord. Anterior two-thirds, take the anterior two-thirds and spare the posterior column and posterior horn. Anterior horn, involvement of the anterior horn only. And I think you know what is poliomyelitis, which characteristically there is predilection to involve the anterior horn. Combined anterior horn cell and pyramidal tract sign. And I think Dr. Abdul Karim described it in motor neuron disease. After that, what is the differential diagnosis of myelopathy? The differential diagnosis of myelopathy, the first four, is look at this photo. This area, which is the parasagittal area, corresponding to the area of the lower limb. The lateral part, the medial part of the frontal lobe, innervate the lower limb. The lateral part is responsible for the upper limb. So any lesion restricted to the medial part, to this parasagittal area, give motor manifestation of lower limb with a sparing or relative sparing of the upper limb, which should be differentiated with spinal cord lesion. But there is no sensory level, because sensory level is specific. It is sensitive, but the most important thing, it is specific to spinal cord, and differentiate that. Parasagittal meningioma here, cerebral venous sinus thrombosis affected this area. Anterior cerebral artery thrombosis also affected this area, and hydrocephalus extension of this the anterior horn of the lateral ventricle affected this area, give impression that it may be spinal cord due to involvement of lower limb with relative sparing of the upper limb. The last one, atherosclerotic Parkinsonism, is something different. It affected the basal ganglia, but due to vascular supply, it will affect the lower limb with more than the upper limb, and can give impression that the lesion in the spinal cord, and should be differentiated from myelopathy. But as you know, Parkinsonism have rigidity rather than spasticity. Okay, diseases of the spinal cord. This is what we take it as a prelude for these diseases that can affect the spinal cord. Myelopathy is any pathological process that affected primarily the spinal cord and causes a neurological dysfunction. This term related to any pathology that affected the spinal cord. This slide is not classical and maybe not accepted. I put all the diseases, but what I want you to know, look at this green titles. These titles, rated in green, is the categorization of the diseases. It divided into acute and subacute. There is no sense to differentiate between acute and subacute. It is the same causes, and no clear-cut time factor for acute and subacute. So the authors put it together. And chronic myelopathy. Chronic myelopathy is the slow progressive myelopathy. Acute and subacute spinal cord lesion. First of all, we should exclude the compressive myelopathy, because acute and subacute spinal cord disease, especially the acute, you should decompress the spinal cord within 48 hours to prevent the permanent damage. Whatever the cause, neoplastic, spinal cord, epidural abscess, subedural, epidural hematoma, compressive myelopathy give extramedullary cord lesion. Okay. If we exclude compressive myelopathy, it will be acute transverse myelopathy, either vascular or inflammatory. The vascular presented with anterior two-third syndrome. It means there is involvement of the anterior horn, spinothalamic tract, and corticospinal tract, with a sparing of sparing of the posterior column. Inflammatory myelitis, which is called transverse myelitis, the patient presented with cord transection, bilateral involvement. Bilateral involvement, transverse myelitis, divided into infectious and non-infectious. The infectious transverse myelitis, usually viral. Fungi and parasite may cause acute myelitis, but it's usually viral. Even the bacterial and mycobacterial etiology are less common than the viral cause. And the most common viral involvement is herpes simplex virus type 1. The non-infectious transverse myelitis have many causes. Para-infectious myelitis due to just like due to post-viral. Nowadays, there is some cases of post-COVID para-infectious. Demyelination, one of the common causes of acute transverse myelitis, is multiple sclerosis, for example, and other demyelinating disease. Transverse myelitis in immune mediated disease such as SLE. But there is other causes like sarcoidosis, which is rare in Iraq, but Sjogren's syndrome should be differentiated. Sjogren's syndrome as a connective tissue disease is rare, but as a cause of transverse myelitis is not rare. So if you take the causes of immune-mediated diseases, yes, SLE is very, very common, but you should exclude Sjogren and sarcoidosis. Neoplastic and paraneoplastic. Paraneoplastic is the immune response to the neoplastic, can give transverse myelitis. And neoplastic, although it is rare, but bilateral involvement may exceptionally be found in lymphoma. 25% of transverse myelitis is idiopathic. If the patient presented with transverse myelitis with no evidence of infection and evidence of inflammation, like abnormal gadolinium enhancement in MRI of the spinal cord, or cerebrospinal fluid pleocytosis, or elevated CSF IgG index, is the criteria of inflammatory process, and steroid and plasma exchange should be given. Chronic myelopathy. The common disease is spondylotic myelopathy. طبعا الناس تسميه سوافان بالفقرات. This term is misunderstanding. May give the impression that the disease is يعني سوافان يعني losing something. It is not losing something. It is change in shape. The spinal cord and the roots have the same shape. If there is change in shape of the vertebrae, there will be at the start irritation to the root, radiculopathy. Then it may cause extra medullary compression to the spinal cord. So the myelopathy will be extramedullary compression. So spondylotic myelopathy start as radiculopathy, then may progress and deteriorate to involvement of the spinal cord in a form of extramedullary compression. Syringomelia, it means extension of the spinal canal, or syrinx, a cyst inside the spinal cord. This disease located to the cervical area and may extend rostrally to the medulla oblongata. The pattern of involvement of the spinal cord in syringomelia is central cord syndrome, because it is predirected to the cervical area. It will give lower motor neuron lesion in the cervical area and upper motor neuron lesion in not in cervical area, in the upper limb. Lower motor neuron lesion in the upper limb and upper motor neuron lesion in the lower limb, with a special sensory loss distribution around the shoulder, nape and the shoulder. Sub-acute combined degeneration of the spinal cord. I don't know why all the world stick to this name, because its name is sub-acute, but it is a chronic. Sub-acute combined degeneration of the spinal cord due to vitamin B12 deficiency. It affected peripheral nerve, concomitant involvement of peripheral nerve and posterior column and corticospinal tract specifically. So there is selection tractopathy. There is other causes of combined degeneration, other causes that the lesion restricted to the posterior column and corticospinal tract, which is folic acid deficiency and copper deficiency. So, subacute combined degeneration of the spinal cord described as myelopathy masked by neuropathy. The patient presented with manifestation of peripheral neuropathy, because due to dominancy, it will mask the clinical manifestation of myelopathy, which is, for example, upper motor neuron lesion, and the loss of sensation in the glove and the stalk, loss of sensation. But the upper motor neuron masked by the manifestation of peripheral neuropathy, which is the lower motor neuron lesion. Familial spastic paraplegia with a selective tractopathy. It's affected only corticospinal tract. But besides that, some patients have what we call it complicated familial spastic paraplegia. And the patient may complain from other manifestation like optic neuropathy, for example. is
دكتور
عيني
بدنا امتحان ب11:30 راح يبدي هسه.
ماشي عيني ماشي. هو ما بقى لي بس هذا السلايد. اوكي. عندي بعد فاسكولار مالفورميشن اللي هي تعطيني كرونيك مالوباثي and neoplastic intramedullary neoplastic and infectious and two inflammatory condition can give progressive myelopathy chronic rather اللي هي primary progressive multiple sclerosis موضوع ان شاء الله الثلاثاء القادم and Sjogren syndrome. Thank you for attention عيني وتقدرون تروحون للامتحان. واللي عنده سؤال يقدر يعني يسال، بس الامتحان الصور قرب بعد.